Hi, my name is Maxwell Weisky,
Hi, my name is Camila Rustamova.
I'm Jasmine Watkins.
I'm Eliza Conception.
and we're all here to do the dementia case study.
Mhm.
Alrighty, let's get into it. Okay, um, this is just we'll go straight to the part one. So William Butch Welka is a 17-year-old male with a history of heart failure, COPD, hypertension, diabetes type 2, and dementia, who has been hospitalized for exacerbation of heart failure 3 times in the past 6 months. He is now a resident of Pineville Estates, a local long-term care facility, the past 4 months because his dementia has progressed and his wife Rita was unable to care for him. When Rita visited Butch this morning, she reports to the nurse that he is more confused and is concerned because Butch is easily angered. Butch insists that he sees his friend Roger, who served with him in the Navy and is in his room. However, he died 10 years ago. Rita approaches the nursing station with tears in her eyes and states, "What happened to my husband? This just isn't like Butch to act like this. Please do something to help him." His personal and social history includes being married to Rita for 51 years. He has 3 children who visit him weekly. Rita comes to visit Butch every day after work. He was a salesman for 35 years before he retired 7 years ago. He believes he is at Pineville Estates for rehab, but his family is concerned that he is no longer safe at home if he were alone. Rita was just awarded guardianship due to his declining mental status. So, with the history of present problem, only using this information, what do we think the relevant data is?
Yeah, just towards the end of that paragraph, I see that um his wife is concerned about how he's acting. She's saying this isn't like Butch to act like this, and looking into the book from behavioral health, being hospitalized can actually cause delirium. So I was wondering if that's something that's relevant.
Yeah.
Yeah, he is also seeing like hallucinations of a friend who passed away too, which hallucinations are like a symptom of delirium too, I believe.
I was gonna say his history also says that he has dementia too.
Yeah.
Mhm. And he also has a history of just multiple chronic conditions like the heart failure, COPD, hypertension. So, with multiple conditions like that, it can lead to further complications down the road with tons of overlap with symptoms and trying to figure out what's happening and what's causing what.
hmm Yeah, if he and also to add on to that, he's been hospitalized what was it, 3 times in the last wait, what
Yeah.
was it?
Last 6 months for heart.
Thank you. For his heart failure. So that kind of just shows that he's having like unmanaged heart failure complications. And with heart failure, as we all know, you have like decreased circulation. And so if he's getting like decreased circulation to like his brain, it can cause like changes in mental status as well, which Rita is showing or like is saying that like he's not acting like himself. So there's obvious some sort of like mental change that's occurring with him.
Yeah, but
Mhm.
the great thing is he has a really strong social support from his family. His wife is there to advocate for him and help him remember, or just be there and recognize that he's not himself. She can
Mhm.
identify those triggers or any coping mechanism maybe that he might have.
Mhm. Yeah, and it also says too that his children visit him weekly too. So he has a really strong social group
Yeah.
of
I wanted
people.
to add too, like, sorry for who mentioned it about like being hospitalized 3 times and it can be like kind of disorienting, but
Mhm.
it looks like he also just transferred to his long-term care facility. Like it looks like the last 4 months, and it's
Mhm.
like right when his dementia progressed too. So I think all the moving it kind of just supports that being in different places can be really disorienting too.
Mhm. Yeah.
Mhm.
And yeah, having hallucinations of friend, does that have to do with dementia, do you guys think? Just
I'm looking
Kind
at
of
the book,
Which book are you looking at?
like the
at the
weird.
behavioral health one.
Okay. I'm gonna look at the heads and see what we got.
Yeah, so symptoms of delirium usually start suddenly, and under that, there's like bullet points, and it says hallucinations and delusions. Yeah, delusions. Incontinence, it even says, is a symptom. Um, memory problems, confusion, disorganized thinking.
Okay, so is what I wrote, okay, may be connected to his dementia, however, it may be symptoms of delirium as well.
Yeah,
Yeah,
yeah.
I like them.
All right. And yeah, for through the social history, I think his social support, his wife being there every day after work is vital to helping us take care of Butch. I think you guys nailed it with makes it a lot easier to identify triggers and
Mhm.
any other history that might be relevant with him.
And they know him better than any of the healthcare providers would. And so they kind of like know his baseline. So if she's saying like, oh, he's acting differently than he normally is, then we should, take that into consideration.
I also
Yeah.
do like for social history, it's mentioning that he believes he's at Pineville Estates for rehab.
Hmm.
And I think it might be clinically significant that his family's concerned that he's not safe at home if he were alone.
Hmm.
Um,
Yeah,
Mhm.
I agree.
Yeah, so just trying to kind of find that balance between like telling him like, hey, you might have to stay here for the remainder of your life, or just, maybe buying into the I don't want to say delusion, but like his thought of like, oh, I'm just here for rehab. I'm gonna go home eventually, because it might be really upsetting and triggering to find out like, hey, your family doesn't think you're safe to be home. You have to stay here. And just kind of finding like that therapeutic um a response to that.
Alrighty, yeah, I think we did a good job looking at his history so far.
Okay.
Um, we can take a look at his vital signs and PQRST assessment.
Okay. I can read that off if you'd like.
Wonderful.
Okay, so his current vital signs, his temperature is 98 point, or sorry, 99.8 Fahrenheit. Oral. Pulse is 60, so that's within good range. His temperature is a little high, but it's not like over like 100.6. I think that's what's determined as a fever. Respirations are 16, that's within normal range. His blood pressure is 115 over 72, also within normal range. His O2 sats are 96% room air, so that's great. For his pain assessment, for the P, so like the provoking, it hurts. He states that it hurts when he's standing and moving. Quality, he stated that it's dull. Region/radiation, he stated it was in his lower back. Severity, he rated it a 4 out of 10. And then timing, he says that it's always there. So he's having chronic lower back pain that's dull.
Yeah, nothing stood out to me with the vital signs as well. He seems
Mhm.
pretty healthy with those baselines. I don't know
Mhm.
if that's out of his normal baseline range, but the 4 out of 10 is a little concerning. I believe that qualifies as mild pain.
Yeah, I think,
Yeah.
yeah.
his temperature is it 99.6? Or it starts as like the low grade fever is at
I think
99.6.
that is a low grade fever,
Okay.
but I need to double check because that's an oral temp.
Hmm. Yeah, I know all the different temps be calculated differently. Let me see if I can figure.
So according to the Cleveland Clinic,
Okay.
um, a low-grade fever is classified between 99.5 degrees and 100.3 degrees. So
Okay.
this would be qualified as a low-grade fever.
Okay.
Okay,
So we'll keep
we will
that in
put that
mind.
in.
I believe fevers, like if you have a fever, that can also contribute to like mental health change, or like mental status changes.
Or to possibly a UTI.
Hmm. Yeah, some sort of infection. Yeah, fever
Yeah.
is a common sign of infection.
Yeah,
I know.
especially with that acute decline in his mental status and the hallucinations, those might be signs of delirium, which can be connected to a UTI. We could
Mhm.
be looking into that later. If we have any other information about that? I think we do, but
Lower back pain. I don't know if I guess the flank. I know we did like the in health promotion, we learned about flank pain and that being
Mhm.
connected to UTIs. I don't know if lower back pain is considered that.
I would think so, because it's like close to like where the kidneys, right?
Right, that's what I was thinking, but
oh yeah.
he did say he always feels it, so I don't know.
Well, at the very least, it's possible flank pain. It doesn't explicitly say if that's what it is, but that's
Yeah,
obviously
so
something we want to keep in mind.
yeah, so according to like the Cleveland Clinic, some causes of flank pain, as you said, UTIs, urinary system obstructions, could be like arthritis, anything like any abnormalities with the spine, liver disease, gallbladder disease, and yeah, and so yeah, it could be some sort of infection.
Alrighty, I think we got the clinical significance of his vitals and pain assessment. I think we're good to move on down to the mental status examination.
Wonderful. I can read that part.
Alrighty,
So
Sorry.
looking, oh,
Is it
go.
okay to go back to the pain
Oh
assessment?
yeah, let's do
of
that.
course.
Oh, I don't know if this is significant, but he did say too that his lower back pain only happens when he's moving around.
Mhm.
So I don't know if that makes a difference.
Oh, okay.
That's something really good to keep in mind. I honestly, I glossed over that, but that's a really
Yeah.
good thing to point out.
Yeah, because it it might be a muscle, it might be like a muscle strain or something.
Mhm.
But we'll see. We'll see as we assess more.
Okay.
All
Alrighty.
right.
Looking at his appearance, he's dressed in a t-shirt and pants. His pants are urine soaked. He's wearing a sweater even though it is summer. His motor behavior, he ambulates with a walker. He has a shuffling gait. He has a clear speech. His mood and affect is pleasant, except when talking about being at Pineville Estates, becomes agitated, anxiety increases, and angry affect displayed, emotionally labile, sorry,
Liable.
liable, can become easily angered. Generally, coherent conversation can make himself understood. He's preoccupied with not wanting to be at Pine Estates, talks about how they are not helping him, wants to go home and get his hunting license so he can go hunting. He reports having seen a friend, Roger, from the Navy, climbing down the side of the building yesterday. No other current evidence of hallucinations. His insight slash judgment is poor, not understanding why he needs to be at a facility and not at home, thinks he is here for rehab, unable to recognize own deficits in functioning. Judgment is poor as well, often asks his wife to bring him takeout food, which she does. Then he eats an additional dinner in the cafeteria. He's alert and oriented to person and place, not oriented to time or purpose, believes it is 2017, able to recognize that it is spring, short-term memory impaired, doesn't always remember that he has eaten, sometimes forgets when wife visits. Long-term memory seems to be intact, remembers personal history. Attention span is adequate when tested, able to state months backwards. Interactions, he's pleasant when spoken to, just a little hesitant to initiate conversation, and he has some suicidal comments, like if I don't get out of here soon, I might just walk into traffic.
Okay.
And the
Um,
first
Okay,
thing that concerns me is his pants are urine soaked, just
mhm.
going back up.
I was gonna
Yeah.
point that out as well. That is
Yeah.
also very important to keep in mind because especially with his history of dementia and possible signs and symptoms of delirium,
Hmm.
That's indicating he's not able to maintain his own hygiene. He's not able to take care of himself.
Hmm.
So that's just something we want to keep in mind when we're taking care of this patient.
Yeah, he's not capable of doing his own ADLs, so it's like his own activity, like
I was
activities of daily living.
I was gonna say too that I seems like it's indicating too that he's possibly incontinent.
Mm-hmm. Yeah.
Yeah.
Another thing that I find concerning, he is a type 2 diabetic, and it seems like his wife isn't maintaining like, or she isn't helping him like maintain like a proper like diabetic balance. Like he's having multiple large meals a day, and she's also giving him takeout food, which we all know is like high in carbs and fats, which aren't really great for diabetics. Um
Takeout, and then he also has lunch at the cafeteria right after.
Yeah, so he's having
Yeah.
multiple meals, which I imagine is not good for his blood sugar.
Kind of tough for nutrition management.
Hmm. Yeah, so there might have to be some sort of like patient and like family education on what like he should be eating or like what kind of diet he should be on.
Yeah, and I can't imagine that'll pose much of an issue with what we know about the wife so far. She does seem very supportive
Hmm.
of her husband, so I think
Yeah.
just proper education on how we should be managing his type 2 diabetes, how we should be managing his intake when it comes to eating healthier foods that
Hmm.
are less likely to lead to hypertension symptoms with things that are high in cholesterol and salts and all of that.
Hmm.
So,
Yeah, it's interesting too because they it says that like his short-term memory is impaired and specifically he doesn't always remember that he's eaten. So that could also be an issue too where like he might have just had lunch, but he might be hungry. Maybe like if he's having multiple like high fatty meals, be he might be I guess like presenting signs with like hyperglycemia. Like if and so like one of the signs and symptoms of hyperglycemia is hunger. So if he like had a big meal and then his blood sugar spikes and then he forgets that he ate, but he has the sensation of hunger, that's gonna have to be something to be managed.
yeah.
That's a really good point.
And yeah, my suspicions of a UTI are definitely peaked in general, and I
Mhm.
feel like there's more and more signs that he has delirium with the UTI.
Mhm.
And so I think managing that can really help relieve him
Mhm.
of these possible hallucin or these at least one hallucination that we know of. And that might help his short-term memory as well,
Mhm.
because obviously having dementia is bad, but having dementia on top of delirium is worse. So if
Mhm.
we can get that under control, I think it'd be really beneficial for our client here.
Yeah. And since it seems like he is incontinent and he is able to like ambulate, maybe like frequent checks with him, like being like, oh, like do you need to go to the bathroom while I'm here and stuff, just to like kind of like coax him into like trying to go to the bathroom more frequently if he has an UTI and he's also like incontinent.
Yeah.
Uh, I'm also kind of thinking too, like, sorry, it's not quite related to like a UTI, but just like with dementia in general. I know like there can be concerns with like coordination and
Hmm.
sensory. So like I'm looking at he's like wearing a sweater even though it's summer, and I don't know if part of it could be because he has a low grade fever.
Hmm.
Uh, and then as far as like coordination, like his gait's like shuffling.
Hmm.
So I feel like I mean I don't know, like I guess it's like relevant. I don't know if it necessarily is saying anything about the decline, but
Hmm. Well, a shuffling gait, we'd have to like check his medications, but a lot of like antipsychotic medications will have like a shuffling gait as a adverse reaction to the medication. I think it's I think it might be like the extra primordial effects. I think shuffling gait is one of those, would be like in that broad symptom.
was that for the first gen?
Yeah, yes, thank you. Yeah,
What medication?
so first gen antipsychotics, so like
Oh, like
haloperidol.
haloperidol.
Yeah, haloperidol is a first gen antipsychotic, and that can cause shuffling gait and those extra primordial symptoms, which are kind of like muscle rigidity, shuffling gait, fever. Fevers, he does have a fever. I'm trying to think of what other things might be. Well, we'll come back to that. I'll look it up.
Right.
But oh, another thing we should consider is he is having some suicidal ideations too, due to his change in scenery. And with some antipsychotic medications as well, when we get to that point, they can also increase suicidal ideations.
Yeah, that's a really good thing to point out. It
Mhm,
obviously saying if I don't get out of here soon, I might just walk into traffic. That
mhm,
might require some interventions of, having a bed alarm on,
mhm,
being cl maybe putting his room closer to a nursing station so he can be
mhm,
monitored more easily. He can be
mhm,
watched a little bit more often because that
Yeah.
is quite concerning with that suicidal ideation.
hmm And also we have to consider too, he was very independent, and because his mental status is declining. He has lost that independence. He has been moved into an unfamiliar territory, or like unfamiliar environment, and that can also be triggering for him too. His wife has legal guardianship over him, so he's pretty much lost his independence. And so it's important to like try to maintain his autonomy, but also keeping him safe because his family thinks he's not safe to go home. So it seems like he's either gonna have to stay at this facility for the rest of his life or have to get like transferred into some sort of like memory. Is this a memory care facility, or is it a long-term care?
This
Um,
is long-term care.
Okay, yeah. If his symptoms do worsen, he might have to get transferred to like a specialty like memory care facility.
yeah.
Yeah.
He also isn't oriented to time or purpose. He believes it's 2017.
Mhm,
Yeah, and that's going back to that short-term memory that we're concerned about because obviously, keeping track of the date is pretty important and losing that very likely connected to either his dementia or delirium.
mhm.
So
Is that short-term memory, believing that it's 2017? That's a,
um
correct me if I'm wrong. I don't know. Maybe
Yeah,
we can
that
look
is a
into
good
the
question.
book.
Yeah, because is like remembering the year part of short term or long term.
I wonder why
let's see.
2017. Did something happen? Long-term memory seems to be intact, so remembers personal history. So yeah, maybe it is short-term memory. I don't know.
I don't know. Well, my
There's
reasoning
probably-
for short-term memory is that obviously the long-term memory you're going to build up is year after year after year. You're going
Mhm,
through the years. That's going to just be in the back of your mind as you go on. The
mhm,
short-term memory, of course, is the short amount of most recent years.
mhm,
And 2017, in our case, 2025, that would be, you know, 8 years ago. So 8 years ago, I mean, that's basically long-term memory, but
Yeah.
I'm just not sure.
Hmm.
I suppose the clinical significance of that is we're just going to keep that in mind when it comes to his memory care,
mhm,
his medications, because if his memory overall is being affected, that's something we want to monitor, and we'll just keep it in mind as we go.
mhm.
Do we feel like we're ready to move on to the current assessments?
I
Yep.
can read that one too.
All right.
Assessments. Okay, so for current assessment, general appearance, he is calm, his body's relaxed, there's no grimacing, and he appears to be resting comfortably in his chair. His breath sounds were clear with equal aeration bilaterally, anterior and posteriorly. Non-labored respiratory effort. His cardiac, pink, warm, and dry, no edema. His heart sounds were strong and regular. S1 and S2 sounds with no murmurs or abnormal beats. Um, Pulses +3, and they were equal with palpation at radial, pedal, and post-tibial landmarks. They were brisk and he his capillary refill was brisk. For neuro, he's alert and oriented to person and place, but not time or date and situation/purpose, so oriented ×2. He has difficulty falling asleep and wakes up about 1 to 2 times during the night. Gastrointestinal, his abdomen is flat, soft, and non-tender, and his bowel sounds are audible per auscultation in all 4 quadrants. For genitourinary, he is voiding without difficulty. He is incontinent of urine and reported that he just changed himself. And then for his skin integrity is intact and his skin is tenting.
Well,
Okay.
tenting of the skin.
Yeah, I was gonna point that out. I know obviously we're dealing with a 72-year-old individual, but if we're doing the proper skin tinting assessment, it should be a sign of dehydration.
Mm-hmm.
So,
We'll put both in. It could be due to age or dehydration.
well, it's just a lot easier for the skin to tint with older individuals, so
Mm-hmm.
it's a little bit less of a
Reliable.
qualifier of a symptom, but obviously if you're doing it like underneath the collar, it should be a nice classic test.
Oh yeah,
So,
the skin turgor.
Mhm.
mhm.
Let's see.
Pulse 3 plus. Is there
Yeah,
anything we think about that? Because that is what kind of stood out to me when it came to cardiac.
Is
Mm-hmm.
that
It seemed
considered bounding? That's
I
three.
think so.
I think bounding is for me see skin.
I wasn't sure if it was 3 or 4. Because I know 2 was like expected. Oh, it's 3.
I'm pretty sure it is pounding.
Oh, is this 3 plus is normal?
Yeah, the National Institute of Health says that 3+ is normal. Pulse 4 is bounding.
right.
It's different than what ATI told us.
Yeah, it's a little different, but well,
But I can see that.
Let me see how relevant this
that's
one.
pretty good though for someone who has a
Um,
history of, numerous incidences of like heart failure and hypertension.
I was
So
Mhm.
gonna say this guy doesn't have edema. He doesn't have like
yeah,
crackles in his lungs. So
Yeah, those are good because those are all signs of heart failure or
yeah.
like fluid overload.
So that tells us his cardiovascular system has been pretty well managed. So
Hmm.
I'm assuming he's been following his correct regimen when it comes to medication. Obviously, we're a little concerned with diet, as we
Hmm.
know with the wife bringing in some fast food,
Hmm.
which we obviously don't want for his cardiac issues, but for the time being, it seems to be well managed. Lung respiratory system appears healthy. He doesn't appear to, for no grimacing, that kind of also goes with the pain assessment of it. He's only in pain when he's standing and moving.
Hmm.
So when he's resting in a chair, there's no grimacing. He doesn't appear to be in any pain.
Hmm.
Um,
I'm
yeah,
also
the
looking.
two things once again that point out to me are the tenting of the skin that we got, the incontinence, and obviously once again, he's only oriented ×2, not to time or date.
I was gonna say I'm also thinking about him having difficulty sleeping too, because I think that's also something that you see in dementia as well. And it's not what's the right word? Like quality sleep if he's waking up 1 or 2 times during the night.
Hmm. And two, depending on the type of medications that he's on, insomnia can be advert or not like but like a side effect to some medications too.
That's a good point.
Yeah.
Okay, do we feel good on this section? Anything else to add?
I think we did pretty good. So we weren't concerned about his pulses being 3 plus.
Yes. Yeah, it seems like a 3+ pulse is fine. It's
Okay.
And
So
I just added real quick with the incontinence of urine. For the time being, his skin integrity is intact, but that has been shown, of course, to lead to loss of skin integrity and could lead to, you know, wounds and ulcers. So just trying to manage the incontinence best we can is something we want to do.
Mhm.
I think
So,
especially, which is good because it sounds like his circulation's pretty good with like the capillary refill, but like kind of going off of what Max said, like especially since he has diabetes too, it's something to
Mhm.
kind of look out for too.
Yeah, yeah,
mhm.
because with diabetes you have that what
It's
is
like
it?
risk of less circulation of
Yeah.
like that for
Oh, delayed wound healing too. He
yes.
at risk for that. So you definitely want to make sure that his skin is clean. It is he did say that he reported that he changed himself, and we do want to like maintain his autonomy, but we do want to like, make sure that he is like maintaining his hygiene. Um, and just making sure like he's wearing like clean and dry clothes. Yeah, just to keep his skin in integrity.
Alrighty. Can move over to the lab results. So current and most recent. That's an interesting way to list lab results, but currently his sodium's at 140, potassium's at 3.4, which is hypokalemic. Also,
Mhm.
yeah, the sodium is in a healthy range because that's 134 to 145. Sorry,
Mhm.
135 to 145.
Mhm.
Uh, Glucose, I'm guessing that's a fasting glucose.
It
Doesn't
might be
say.
just like a CBG glucose too.
Yeah. Was 225, which is pretty hyperglycemic. That's a little expected with his type 2 diabetes.
Mhm.
And his creatinine was at 1.2. Is 1.2 nice and healthy?
I'm trying to look it up in the book.
Oh yeah,
Okay.
in the diagnostic.
the diagnostic. Isn't it like 0.7 to 1.3 or something like that?
So
I don't know what the book. Let's check the book.
the diagnostic textbook says that for like healthy individuals, creatinine should be 0.5 to 1.1.
Okay.
So for a in the book for
Okay.
61 years and above, a male, 0.7 to 1.3.
Okay. So that is the correct. Sorry.
Just considering his age.
Hmm.
Yeah, I'll just throw that in there as a
He's in his
value.
70s.
Yes, he is 72
Yeah,
years old.
yeah. Hmm.
Okay. So everything besides his potassium and glucose seems to be managed here. And his most recent, he is now borderline on hypoglycemia or hyperkalemia. So his
Hmm.
potassium's just within range. So managing that, of course, because that's a very important electrolyte to keep balanced. And his glucose is a little lower. S- So, and then his creatinine is still within range.
So, when looking at these lab results, most recent compared to current, so I guess like when we're looking at like the trends, he has been like borderline hypokalemic, and now he is hypokalemic. And so some like signs and symptoms of hypokalemia is kind of like just like full body, like kind of like depression, like you're gonna have like changes in like mental status. He is not hypo tensive, but to monitor his blood pressure when dealing with that. Also, I'm not sure if they would have like access to like ECGs, but you would want to monitor his ECGs for any like heart dysrhythmias since he does have heart failure, and if he doesn't have his potassium balance, then that can also lead to those.
Also considering his medications, if it can affect his electrolytes, if it can hit
Hmm.
his
Yeah.
potassium.
Yeah, like diuretics, if he's taking any diuretics for his heart failure, that can
Yeah.
cause that. Yeah, so I guess the trend for this, his potassium's getting worse. His glucose is also getting worse. Um, that could be because like he is having multiple, or like his wife is bringing in fast food for him. So maybe just again, just like reiterating like patient education when it comes to like a diabetic diet.
Mhm.
Alrighty. Yeah.
Also, I know his creatinine is within normal range.
Mhm.
I don't know if you already mentioned this, but it is, or no, never mind. I was reading it backwards. Correct. Or no, am I reading it correct? Most recent was before the current one. Yeah, so it's going up. His
Mhm.
creatinine went up by 1.1. I don't know if that's something we want to add just to look at the trend.
I think it's pretty because if it's like right, it's very close to 1.3. I think it'd
Mhm.
be important to keep an eye on.
Mhm.
So just to clarify, current is the thing that happened before most recent.
No, it happens right now, and most
Yeah.
recent was like an hour ago.
Okay, got it.
So, like an hour ago, for example, he was at 1.1, and then right now he's at 1.2. And then what if he goes up to 1.4 or something? I don't know. I would keep an eye on it. Close to the higher.
Alrighty.
Sorry, just one more thing. Do, 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 do. Oh, I lost it. Never mind. We're good.
Ready to move on to the complete blood count.
I can read that if I can find my little sheet. Sorry. Okay. Okay. So, okay. So, are we looking at the urinalysis?
The
Oh no,
CBC.
sorry, sorry, the CBC. Okay,
Yeah, that
so
one.
his most recent, his white blood cell count was 5.8. His HGB, what is that, hemoglobin?
Yeah,
Yeah,
that's
hemoglobin. Yeah,
hemoglobin.
hemoglobin was 14.5. Platelets were 198. Percentage of is that neutrophils?
Yeah.
Okay, percentage neutrophils 52, and then bands 0%. Current white blood cell counts are 6.0, so they went up a little bit. Hemoglobin is 15.2, those also went up. Platelets 202 also went up. Neutrophils also increased by 3% and is now at 55. Bands still at 0.
Okay, so for the neutrophil lab values,
Mhm.
a healthy amount is between 50 to 80% according to the Mayo Clinic.
Mhm.
So I mean, he's within range, but he's just on the lower end.
Mhm.
Platelets, I believe that's 150,000 to 450,000, right?
For platelets.
That up?
Yeah, 150 to 450. That's how I remembered it. Yeah. So his platelets are in good range.
Mm-hmm. Yep.
Okay. And then
Hemoglobin, I'm pretty sure it's up to 17, like 14 to 17 for men. I will look it up though.
I have the common reference ranges for healthy adults from the lab, the MedSearch lab, and it says for males it's 14 to 18.
15 to 18.
So
Okay.
close, close.
All right,
Okay.
fantastic.
So
And
those
then
are,
do you have the white blood cell count?
I think those should be
10. Or
6 to 10. Yeah, six to
yeah,
10.
it's the 10.
Here it says 5 to 10. I don't
5
know.
to 10. Okay, there you go.
Okay.
So looking at these labs,
These two, just to make sure.
yeah. Looking at the labs, his white blood cell counts have gone up a little bit, but they're not significantly high. So I know we've been considering a UTI. I guess we'd have to like look at this his urinalysis for that because like his white blood cell counts aren't too high. His neutrophils are on the lower end. So again, we'd have to look at his medications because a lot, like, because I just did like a huge like medication for like pre-work for clinical like all antipsychotics, but a lot of antipsychotic medications will cause leukopenia or like neutropenia, so they'll like lower the white blood cells, which can increase your susceptibility to infections.
You said neutropenia?
Yes, neutropenia.
Mhm.
That's
And
some really good
they,
experience you have.
yeah,
I had to for clinical for behavioral health, we had to do like the medication lists. And so my patient had like 13 different medications and she was on a lot of antipsychotic medications. And this little book here show that like a lot of the antipsychotic meds can cause neutropenia as a adverse drug effect.
So interesting.
Yeah, it is.
Yeah, I'm
well,
hoping later we get to see any prescribed medications. It doesn't.
Oh, he
Oh,
does.
yeah, we
Yeah.
do.
Okay,
All
good.
right.
We can look
So
at
we'll look at
those.
those later.
Hmm.
Camilla, I believe you were saying something earlier and I may have interrupted. I apologize.
I don't even remember anymore.
You're
But I
good.
did notice that the most recent was 52 and then they went up to 55.
Hmm.
So they're technically improving.
Yeah.
And same with hemoglobin is improving.
Hmm.
Everything's improving. Platelets
Yeah.
are going up.
Hmm.
Do you guys know what bands are?
No, let's see. Yeah.
That's a fantastic question.
You know it's 0%, but immature neutrophils. They're released from the bone marrow in response to infection.
Oh,
So that's a good thing that they're zero. So
yeah. So he's not fighting any infections, it seems, right now.
Got it. So that's good. And we saw that earlier in his vital signs, he does have a low-grade fever,
Hmm.
which I'm not sure if him not having an infection is honestly bad, especially with our suspicions of a UTI. You would kind of,
Hmm.
I mean, yeah, that is what we're saying, huh? We are seeing an increase in all of his blood count.
Hmm.
So,
Um, yeah. Um, some I know I keep talking about the meds, but some antipsychotic meds can cause hyperthermia. So maybe he's having some sort of adverse reaction to the medications. But he's not technically hyperthemic yet. Because I think
mhm.
that's
yeah,
like, yeah, but I don't know, we'll see. We'll see.
I, was that also the, because I remember seeing that too when we were studying for the exam. Which medication was it that caused the,
That one's- Mhm.
load up real quick.
Oh, H. Okay, haloperidol can cause oh no, haloperidol causes hypothermia. Oh, but it
Oh,
also can cause neuroleptic malignant syndrome, which would have fever, restlessness, somnolence. Something to keep in mind.
okay.
Okay.
Let's move on to the urinalysis now. So, from most recent to current, just focusing on what's changing, the specific urine gravity decreased by 0.003 thousandths. Um, Everything else is the same. There's white blood count that increased to 4, and there's trace amounts of bacteria and a few epithelial cells.
Okay.
So with a UTI, I do know obviously we're going to be seeing trace amounts of bacteria. So that might indicate the significance of the UTI. And then white blood count would normally be raised in a UTI, so that also corroborates.
And also, nitrates would be commonly found in UTIs, and he's negative for nitrates.
That is, yeah, an interesting rule.
I don't think I don't really think he has a UTI anymore.
Maybe
Hmm.
it could be a resolving one.
Yeah, maybe we see his medication history if he has any like antibiotics. What's the significance of epithelial cells in urine?
Um,
Let me see.
So epithelial cells, correct me if I'm wrong, obviously, it's the shedding of something going on in the genitourinary system, and I think commonly it has to do with kidney stones because kidney stones are going to be irritating the epithelial line. It's going to be causing a shedding of those cells, and that's when you're going to start seeing them. I'm not sure if that's connected to past or present UTI, but that's what I know.
Curious about that too, like, or just any kind of trauma in general. Because is that what I don't know if I could be wrong too. I don't know if the ureter is lined with is it epithelial cells that it's
Yeah,
oh,
it's called urothelium, but
okay.
it shows up in urinalysis as
Looking
epithelial
at,
cells.
I apologize for interrupting. Looking at the book, epithelial cells can be shed from the bladder as a result of tumor infection or polyps. Um, they can also result from desquamation of renal tubule cells into the lumen of the tubules and collecting systems.
Okay.
The presence of occasional epithelial cells is not remarkable. Large numbers, however, are abnormal.
Okay, so
Okay.
he has a few, so it seems like it's normal for
Yeah,
So I'm not
it's
even gonna
not
put that in relevant labs.
okay.
treat.
This
Yeah,
the specific gravity it has decreased a little bit.
yeah.
Um, what do you mind seeing what the range is for that?
That one I know is 10 to 20
10 to 20. Okay,
range.
so
Yeah,
it's still within normal range.
Yeah.
Um,
10 to 25. Sorry, 10 to 25. I
okay.
studied that for the exam from the book as well.
Cool.
I
Okay.
also I don't know if this is like relevant. I'm like wondering is do all bacteria because I'm like kind of going back to like maybe a UTI.
Mhm.
Could it be like the type of bacteria he has? Like maybe it might be one that doesn't like convert nitrite, or is it like encompassing all like do all of the bacteria in UTI are they able to?
That's a good question. I
Yeah.
I personally don't know because I just know that like nitrates in the urine is a pretty good indicator of a UTI, but also bacteria is too. he's negative for the nitrates, but yet he is positive for some bacteria. So
His WBC is also
I was
increased.
looking I was looking at the white blood cells. It has to be 5 or above in the
I
urine to be
I
Oh,
considered
just found that as
UTI.
out as well. I was about
Mhm.
to mention that. I just looked through a medical manual and it was
Yeah, this
talking
is
about the
straight from our
urinalysis
book.
values. Yeah.
Mhm.
sorry, could you repeat that? The white blood cell counts have to be higher than 5?
Yeah, it has to be
Correct.
5 or above
Okay.
to
okay.
be considered a UTI.
And his is at 5, right?
This
Or is
is
it
at 4,
4?
correct?
Okay.
It was 0, but now it's at
Oh,
4.
I see I see it there.
Maybe
Yeah.
I would put that in.
Yeah.
Oh,
Okay.
you know what I'm now realizing? It's just talking about relevant labs. So we can include everything we just talked about, and we can just say it's not important.
Yeah, that's true.
I just
We
realized
we
that.
can. We could say improve, worsening, or stable.
Mhm.
Okay, so white blood cells higher than 5 indicate a UTI. No indication of, oh wait, I'll just say stable.
Yeah.
And then the last thing we didn't talk about was trace amounts of bacteria.
I'm trying to find that in the book.
Yeah, I'll take a peek too. Infectious organisms.
I know specific gravity too, I think is something they check with UTIs, but I don't know why.
For dehydration, I'm pretty sure
Maybe, yeah.
Yeah. So
how
dehydration.
concentrated it is. If it's higher than 0.025, it's a sign of dehydration. And if it's lower, it's the opposite,
Okay.
like
That makes sense.
dilution. Mm,
And I think too with UTIs, the specific gravity would be higher too, because it's kind of like the urine is more concentrated.
That
mhm.
makes sense.
Camilla, you said large amounts of epithelial cells indicate cancer. You said polyps.
Yeah, polyps, cancer, and UTI.
Um, maybe he has polyps because he has that flank pain too. I don't know if polyps necessarily cause I forgot what I was saying. Oh, cause flank pain.
Yeah. Trace amounts of. Sorry, I'm still trying to find bacteria in the book. Bacteria. Okie dokie.
And it's saying that polyps would cause blood in his urine, and he's not doing any of that. So
Yeah. Mhm.
okay. Do we want to put it all together and think like a nurse?
Clinical picture.
Yeah.
So what is his problem? I guess like deterioration of mental status.
Right.
Yeah,
I agree with
that's a
that.
nursing diagnosis. Yeah.
Yeah.
Um, and then the patho in our own words.
So I would just to butt in for a quick second. Obviously, I completely changed my mind about the UTI with his current urinalysis. I don't believe there is a UTI. I
Mhm.
mean, obviously, his urinalysis kind of indicates like nothing significant.
Mhm.
everything seems to be pretty stable. So for like why his deterioration of mental status is happening, do you guys have any theories in general?
I think it might be also related to what Jasmine mentioned earlier. I think it was Jasmine who mentioned it, but it was since he's at the hospital again, like I wonder if he's just getting agitated with like the environment's changing frequently.
Yeah, he mentioned multiple times how much he dislikes the facility.
Yeah.
He
Mm.
sees his friend, his buddy there. He thinks it's rehab. He thinks it's a different year.
And he also has that diagnosis of dementia too. And these are all common symptoms of it. Um, yeah, and his wife said that he's not acting like himself as well.
Mhm.
I wonder what the primary concept of that would be, what they're asking. Oh, I
Primary
guess it's a
problem.
management. Wait, okay. Why how the primary concept is his primary problem? Management of care?
A little bit confusing.
I mean,
Um, primary concept. Well,
like the primary like referral or something to like a
um,
department.
Interpreting clinical data. What is the primary problem? What primary health related concepts is this primary? Okay, it's saying like what primary health related concepts does this primary problem represent?
Neurological?
Yeah, there's a
Yeah, say
neurology.
neurological. What was that ATI module's name?
Neurocognitive disorders.
Oh,
Yeah, so
there's the primary
neurocognitive
concepts.
disorders.
All right.
Okay, guys, we're getting somewhere with this. Okay, do we all agree? Feel
Yes.
comfortable with that as far
Do
as
you want to add anything onto the pathophysiology? Did I word it and phrase it
oh, let me see.
correctly?
I guess like the pathophys. Yeah, I guess maybe we should talk about like dementia a little bit.
Let me look in the book.
Okay. Um,
See if I can find.
I know, didn't we did like a case study this
That's
week.
Yeah.
exactly what
Question
I'm searching.
and
I'm
everything.
searching up the CAMS assessment.
Mhm.
Yeah, assessment. Let's see.
15.
Okay, so using this delirium assessment,
Mhm.
is there evidence of an acute change in mental status from the patient's baseline?
Yeah.
Yes.
Okay, so we know that there is an acute onset.
Okay.
For inattention, did the patient have difficulty focusing attention, being easily distractible, or having a difficulty keeping track of what was being said?
And his
Um,
attention was pretty.
Attention span is adequate when tested, able to state months backwards.
Okay. And it didn't fluctuate during the interview. Obviously, we don't have that information. Tend to come and go, or increase or decrease in severity. Okay. It seems like he's testing negative for inattention, which,
Mm-hmm.
with that being said, you need acute onset and inattention to be diagnosed with delirium.
Okay.
Oh.
So, according to the CAM assessment, at the moment, he cannot be diagnosed with delirium.
Okay.
So, with that being said, that brings us back to the dementia.
Mm-hmm.
If we can't diagnose it with delirium, that means that his dementia really is rapidly progressing.
Mm-hmm.
And so, with dementia, we might be looking at a diagnosis for any specific types, like Alzheimer's. We might be looking into some family history, because with neurocognitive disorders, there's all sorts of things that we need to be paying attention to. And just like you were saying, Jasmine,
Mm-hmm.
environment can really shape different types of manifestations.
Mm-hmm.
So,
I'm trying to see too. There's like a video I used to watch. Her name was Teepa Snow, and she was talking a lot about like the clinical manifestations of dementia and how like it can affect like your vision and your sensory,
Mm-hmm.
which I feel like could kind of explain why. I'm trying to find it in our old patho book from last term to see if there's something about it there, but I can kind of imagine that having like the vision and sensory loss on top of like the environment change, I could kind of work out like why he would have like the hallucination of his friend.
Mm-hmm.
Um, see if I can find it though.
Yeah, I added the attention span because that just completely changed the picture for us.
Mm-hmm. Yeah, because there's I was looking at the med search book, there's different types of dementia, and so we're not really sure like what type he has. Because he doesn't have a history of stroke, does he?
he has a history of multiple other cardiovascular disorders.
Yeah.
Uh, Heart failure, hypertension, type 2 diabetes.
Mm-hmm.
I know type 2 diabetes increases your risk of a stroke, but obviously he doesn't have a history of a stroke.
So we can, I guess that rules out the vascular then, dementia.
Yeah, I mean the
So we could, does he have Alzheimer's?
No, he just has a diagnosis of dementia.
mhm.
Okay.
So
Mhm. We can talk about the progressive loss of neurotransmitters like acetylcholine.
mhm. For his dementia.
Yeah, that could be our patho.
Yeah, he's losing those neural pathways, and so he's forgetting basic things and
All right, so I kind of just said what you just said, Jasmine. There's a loss of neural pathways in the brain, causing short-term memory loss and impairing his ADLs.
yeah, that's what I got.
Yeah,
I kind of wish we had more, but
Yeah.
should we go on to medications?
of course.
I got
Okay.
this handy dandy guy too. So okay. I can go over them since I'm very passionate. Okay. So the orders we have neuropsychiatric evaluation urinalysis. We have haloperidol, 2.5 milligrams PO 2 times a day. Acetaminophen, 325 milligrams, 2 tablets PO every 6 hours, PRN. Insulin, glargine, 10 units sub-Q, HS, so that's like before bed. Um, increased memantine, to 10 milligrams PO daily. Um, donazepam, 5 milligrams PO daily. Trazodone, 50 milligrams PO at bedtime, PRN. Okay. Uh,
Isn't Donepezil, isn't that for Alzheimer's?
Let me see. I can hopefully it's in this book.
All
Um,
right, you'll do Nipazil, I'll do Trazodone.
okay. Okay, I have it. So it is a acetylcholine esterase inhibitor. Yes, it is an anti-dementia medication.
Okay. It's not like specific, it's just like dementia as a whole.
Yeah, let me see what it says. Yeah, it just says to treat mild Alzheimer's disease. Yeah, that's all.
Just adding in,
Trazodone, sorry,
sorry, go
go
ahead.
ahead. Oh, I was gonna say Trazodone is an antidepressant.
Okay.
I was just adding in the obvious ones, the acetaminophen, Tylenol for his mild fever, possibly. That's why he has a PRN. And the insulin, long-acting glargine, is to manage his type 2 diabetes.
hmm What type of antidepressant is trazodone?
Trazodone, this is gonna test my pronunciation skills, is a trizolapyridine derivative.
I was gonna say, isn't trazodone used for sleep? Like, since he's
Just
not,
says it just says indications to treat major depression.
Yeah, I think trazodone, like an off-label use for it, I think is for sleep. Maybe that's like why it's taken at night.
and like
But
also he was having sleep disturbances too, so I wonder if the doctor is prescribed it, yeah, like at night for sleep.
So for nursing considerations for trazodone, just going through, NDH here. Monitoring pa the patient closing for serotonin syndrome, including agitation, coma, diarrhea, hallucinations, hyperreflexia, hyperthermia, incoordination, um, libel blood pressure, nausea, vomiting, tachycardia. Um, we got three of those symptoms.
yeah,
We
so
got a history of hallucinations.
hmm
We have not hyperthermia, but we have a low-grade fever,
hmm
and we very much have agitation.
hmm So he might be having serotonin syndrome from his trazodone. But also his trazodone is PRN, so I don't know how frequently they are administering that, but serotonin syndrome is a um good thing to
Bitter.
go to get to consider. Um, so for the first part of this, the neuropsychiatric evaluation urinalysis, the rationale that for that would be like you want to measure serum serotonin levels to make sure that he's not getting serotonin syndrome because these medications, whether it be antidepressants or anti-anxiety medications, they are increasing the amount of serotonin and like dopamine in the body. And as we know, too much dopamine can cause like schizophrenic signs and symptoms, while too little dopamine can cause like Alzheimer's symptoms. Um, and then too much serotonin causes that serotonin syndrome.
I couldn't type that fast to get
I'm
all of that.
sorry. I'm sorry.
You're so
So
fine.
Yeah, so like anti-anxiety and antidepressants can like alter dopamine and serotonin levels. And we want to monitor for if like they have like serotonin syndrome or if they get like those extra primordial symptoms and like those Alzheimer's symptoms as well when looking at those.
All right,
Uh,
that time I got everything.
okay.
I'm looking at
Sorry.
haloperidol on the
Mhm.
Davis's drug app,
Mhm.
and some therapeutic effects are diminished signs and symptoms of psychoses.
Okay. So that would be an expected outcome for that.
Yeah.
What were his electrolytes? Let's see. Sodium's okay, potassium. And stuff.
Yeah, like I wish that they showed us his medications from before.
I know it would have, yeah, if it was.
Yeah.
um,
Because I like the point that you brought up where I wonder like if some of like the symptoms would have been like medication related, but
mhm. Yeah, because like haloperidol can cause neutropenia. Even though he's not neutropenic, he is like borderline. I think the well, what was I looking at earlier? The donazepam also can cause neutropenia,
yeah.
or
Oh,
can it?
so does Memantine.
Oh, I'm sorry, it causes anemia, but mhm.
Looks like haloperidol is used for patients with schizophrenia who require long-term antipsychotic therapy or for agitation or aggressive behavior, um, manic states, drug-induced psychoses, Tourette's syndrome. Sometimes it's used for nausea and vomiting from surgery or chemotherapy. So it
Mhm.
looks like he gets this to manage his behavior.
Yeah, for the haloperidol.
Hmm.
Yeah, because it's a first gen antipsychotic medication.
Hmm.
Um,
And I am pretty sure in that paragraph in the beginning, they mentioned his mood and affect. He was pretty agitated. We'll go back on that. Angry affect displayed. He becomes agitated when he talks about Pineville Estates. Anxiety increases, can
mhm,
become easily angered. So
mhm.
most likely why he's taking that.
I'm having a hard time typing on here on the sheet, but uh,
It's going up and down.
let me see. I'll look at the man time. Let's see. Well, okay, so I guess for like the expected outcomes for the urine analysis, we want for like dopamine and serotonin to serum or like the serum levels to be within expected range.
Right, my dopamine levels, serotonin levels.
Good.
That's not about right. Wondering just those two levels. Also, norepinephrine.
Yeah. Do any of these affect norepinephrine?
I know trazodone does.
Okay,
Trazodone, yeah.
the norepi as well.
Mm,
And then so expected outcome,
Mhm.
that's a I'm trying to figure out what the difference is between expected outcome and rationale. Rationale is like the reason why this was ordered.
Yes. So rationale, like why was this ordered? Expected outcomes, what do we expect this medication to do for this patient? So like with his memantine, since it helps delay the progression of dementia, expected outcome again would be like delayed signs and symptoms of dementia. Or like slow progression, which I guess is the same thing of
I think
dementia
like
symptoms.
usually like I'll like think of like we'll say like with Tylenol, it's like the rationale of why someone would take Tylenol is because they have a fever. So the expected outcome is after taking Tylenol, my temperature is going to be back down to 98 degrees. If that, I don't know if that makes sense,
No, that
but
makes sense. Right.
I know I'm like struggling like figuring out what to type for the expected outcome for Mementi.
Yeah, I would just say slow
Same.
progression of dementia symptoms.
Honestly, yeah.
That's, I think
Because
that
it
works.
doesn't solve it. It doesn't
Yeah,
cure
it's not
it.
going to cure it, but it will at least slow down his
I can also look it up on the app on my app because it gives me outcomes too. Mateen.
Got that right. It's okay.
I have so many tabs open from looking at stuff.
Cognitive enhancement, decreased symptoms of dementia slash cognitive decline. So we can say that. Decreased symptoms.
Okay, symptoms of
Yeah, that's what you wrote basically. Decreased symptoms of cognitive decline, dementia.
Right.
Looking at the behavioral health book, some helpful interventions include making sure the room is quiet and well lit and having clocks and calendars within view, inviting family members to spend time in the room, allowing for undisrupted sleep when possible, administering prescribed medications to distress clients at risk to themselves or to others to calm and settle them, such as haloperidol. And our patient also has haloperidol on his prescribed medication list.
I was gonna say too, like since he is like taking haloperidol and because of like his shuffling gait and his incontinence, I and the confusion, like I feel like he's like a pretty high fall risk too.
Mhm.
Yeah,
So
so
like
definitely having as fall at risk. And also too maybe having his room closer to like the nurse's station because due to like that fall risk and also he's not happy at the facility too and so he might try to elope. He could be an elopement risk as well. And so just having like an extra like set of eyes on him constantly.
I think especially with like that agitation too, and like it seems like behavior is a little unpredictable. It'd be good to be closer to the nurse's station.
Mm-hmm.
And I know something that you've mentioned earlier too with his skin. I think he's like also at risk for skin breakdown because of the incontinence too.
Mm-hmm.
Yeah.
Mm,
One of the also isn't incontinence one of the fall risk assessments on the Braden scale?
I think so. I actually on the Braden scale, I'm not sure.
I can look it up real quick.
The Braden scale is for it's for pressure ulcers.
Yeah, it's for pressure.
Oh,
Oh.
sorry. Oh, yeah. Did I say Braden scale earlier?
I just said Braden scale because I thought that is for fall risk, but I it's literally just called the fall risk assessment.
There's so many scales.
Yeah.
Um,
It's important too, though, like the
yeah.
Braden scale for him because
Mhm.
of the incontinence.
Yeah, and he's also diabetic too. So he could have, if he
Yeah,
does develop a wound, it's going to be really hard to make to heal.
yeah, yeah. Oh man,
Um,
especially with like a pressure sore too.
mhm,
It's like a higher risk because he doesn't have that circulation.
yeah, exactly. Um,
I'm going to look into Lippincott and look at some nursing interventions for dementia.
okay. What
All
would
right,
you?
so I'm just gonna go over what I just wrote. The thing I just wrote was fall precautions due to shuffling gait, short-term memory impairment, agitation, and I think we mentioned something else that was significant with precautions.
I think it was just, since he's like taking medicate like trazodone and haloperidol, so it's kind of more like downers type medication,
Yeah, sedatives.
sedatives, yeah.
Right.
So that
Mm,
can
okay.
they can decrease his level of consciousness.
Mm.
All right. And fall risk precautions include placing the room near nursing stations, using bed alarm. Um, don't isn't that also raising up all four rails of the
No,
bed?
it might
No.
be,
No, it's the opposite, right? You don't want to do that.
yeah.
Yeah,
Okay,
because
Oh,
raising all four rails is considered a
A restraint.
yeah,
got it.
but it is good to like make sure the bed's like low and locked.
mhm.
Mm.
Patients educated on the nursing call button.
Yeah, the call bed, making sure it's nearby.
Yeah, and he knows how to use it. Of course, if he has short-term memory, maybe he won't, but
Or not.
Being adamant about it.
just keep reassuring or like re
Like
uh,
putting like maybe a sign on the wall.
mhm. So what would we consider like our main priority to be with him?
So I'm looking at nurses' labs. It's also a
Mhm.
great place to look at stuff for care plan. I'll send you
Mhm.
guys the link. On
Like,
here, I thought preventing injuries and promoting client safety might be like the priority with a
like
confused
that.
patient. So placing forms of identification on the client and keeping the client free and like without any pointed objects or harmful liquids, especially with his statement he made that was recorded by a nurse that he wishes he can walk in the street, something like that. Like it was
Yeah.
a suicidal ideation. Playing soothing music is also another great thing. Um, Reduces agitation.
So all these interventions come
Mhm.
together to prevent what did you say the main intervention was to do?
Yeah, this main intervention is for safety, client, prevent injuries and promote client safety.
And then I guess our expected outcomes would be no injuries, um, or risk to patient safety.
Mhm.
I'm also going to move this inviting family members into the room down to the next section too for the
All right,
psychosocial.
Jazz, you said decreased risk of injury and what? Sorry, I didn't.
And decreased risk of injury and no,
Um,
I guess increased patient safety.
yeah, increase patient safety.
Got it. Lovely. Okay. Um,
Do we feel good with this?
Mhm.
We
yeah,
got
we have a lot of things on maintaining the environment.
Mm-hmm. Yeah, because that's
Um,
important with dementia patients.
Yeah.
Mhm.
yeah. So I'll just work on I guess after we're done with this recording, editing this all to help manage the environment. but we can move on to number 4 for now. We have enough here.
Or
It's just a
functional
little cluttered.
abilities. I'll write that on this side. Expected outcome restore functional
Okay,
abilities.
great.
think I'm gonna separate the fall risk too and write down the patient will not have a fall. Not
Yeah, there you go.
Okay. So psychosocial priorities, inviting family members into the room. I'd even go a step further and add incorporate them into care.
Mm-hmm. Yeah. Because as I was saying earlier, it's like they know him best. They'll be able to like help us like establish his baselines and stuff. They also know like what like kind of coping mechanisms maybe he previously had whenever he was stressed out. His wife could be like, oh, like he likes to listen to this type of music. So just kind of getting her input on that would be beneficial if like he's not able to express that himself.
I'm kind of like going along with that too. Since they know him best too, they probably might have better methods of like redirecting,
Hmm.
especially if he gets like agitated, which is helpful.
Yeah, there's also another side to the psychosocial aspect, like referring the family to social services or other support services, because it is really hard to deal with a family member that's declining cognitively and he's agitated, and even with his wife's statement saying he's never been like this before.
Mhm. Okay, so for priorities, we're going to invite family members into the room, incorporate them into plan of care. Our rationale is that the family members know the client best, they understand his mechanisms, know his baseline behaviors, and they have an insight on redirecting the patient back to his normal baseline.
Something I'd also like to add is maybe involving the patient in like social activities. So if the facility has like, I don't know, like Friday night bingo or something, because it's important to like establish routines with
Yeah.
patients who have dementia. So like if we can get it, if like they have like scheduled activities, try to get him involved in that as much as possible.
And kind of like going off of that too, because he is like in a long-term care, so I wonder like if kind of reconsidering placement
Hmm.
also be like somewhere where he can have like more involved like activities
Hmm.
that like fits him a little bit more better, like something more appropriate with what he's going through.
Hmm. Yeah, especially if he declines further, he might have to go to a special, like a specialty unit that can accommodate for patients with dementia or
Yeah.
memory issues.
That might actually go in hand with referring the family to social services so
Hmm.
we
Yeah.
can find them a better place.
Yeah. Okay. So in this, geez. Yeah, I'm gonna clump that all into the family using social services because it seems like with the patient relying so much, or being able to, I should say, being able to rely on his family, we should utilize that by really involving them into patient care, um, using social services, replacing the client, like you were saying, Jasmine, with and Eliza with the facilities that he might need if his dementia progresses further, all in the name of keeping the patient safe, basically, and making sure that he's cared for and monitored. So that's kind of our expected outcome for a lot of these is making sure that we're managing his dementia, we're managing his neurological symptoms, and that we're monitoring him for any changes.
Hmm.
Also, another expected outcome could be reducing caregiver burden.
Mhm.
Yeah. That's kind of what I like too about kind of like what both you and Max are saying about or like incorporating family into the care because then they could still be involved without having to deal with the caregiver burnout.
Mhm.
Okay. I'd say that's pretty good with the psychosocial priorities.
Yep.
We're just mainly trying to address, once again, the patient's safety.
Mhm.
Um, their vital intervention they need right now is for their neurological behavior and symptoms.
Mhm.
So that's what we seem to be managing with that.
Mhm.
You
And
want to move on to education?
yeah.
All right.
So managing his type 2 diabetes. Him and his wife aren't following like diabetic like diet protocols. Like he's eating multiple meals. Like I mean he's supposed to, but like he's eating a lot more meals a day than he should. His
Fast food.
yeah, fast food especially, which is high in fats and carbs, which is not necessarily something you want a diabetic to eat a lot of. Also his blood sugar seems to not like he's kind of getting unmanaged, like he's becoming hyperglycemic, which can cause things. uh,
No, no, no. Yeah, for sure. Yeah, fast food's going to be high in sugars. It's going to be high
mhm,
in salts. It's going to be high in fats, all of which are not going to be managing his chronic diseases of his cardiovascular diseases is what they're not going to be helping with, let
mhm,
alone his dementia that we're really worrying about in our other interventions.
mhm. Yeah.
So,
And then also maybe family education on what to expect with with his disease progression. Unfortunately, he's not going to get better. He's only going to get worse. So just kind of maybe having like mentally preparing them for that, and providing them those like resources to help them like find coping mechanisms for this.
Yeah. I also wanted to add in just teaching proper hygiene because he is incontinent and
Hmm.
um that be from a healthcare provider or from him or
Hmm.
from family, whoever it may be, it's still someone will end up doing it. And it seems like he was able to change himself after he voided himself,
Hmm.
at least in the earlier,
Yes, that's good.
pretty sure. So maybe just, educating or reminding him of keeping on top of it and why
Hmm.
might be important. And family, of course, because
Hmm.
even when a healthcare provider isn't there, maybe family can remind him.
Hmm. Um, I mean, more like priorities, like medication, like
Yeah.
monitoring, so like monitoring for like severe like adverse effects to his medications, since these medications, like a lot of them like involve the central nervous system, a lot can go wrong with them. So just kind of like what signs and symptoms to look out for with these meds.
already monitoring for adverse effects as many of the patient's medications are affecting his nervous system, which can result in serious side effects.
Mm-hmm.
And I'll even say such as serotonin syndrome because that just came up with the trazodone.
Mm-hmm. I think I have it.
Oh, sorry.
No, you go ahead.
I was gonna say too, when I was going over the Mementine too, there was also like a risk of suicidal ideation too, which is what they're already monitoring him for.
That's
So
really good to include. Yeah.
Yeah.
I'll say side effects such as serotonin syndrome and suicidal ideation.
Mm-hmm.
Did you guys hear that?
No, would you?
Okay, that's good. I just got a call.
Right.
It was
Oh.
very loud. Awesome.
Yeah, I mean, I'd say that's pretty dang good education.
Yeah,
Yeah,
I would agree.
I think we should be proud of ourselves, guys.
Yeah,
Yeah,
I am proud of
Good
us.
team.
yeah,
Tap on the back.
I
good
would have
job.
liked to have done this alone, but
I think I
Thank
will go through this probably after Zoom and add any of the sources that I've used and like the dates and cite
I will
citations
as well.
throughout the whole thing, and I'll add it in the end as well. Feel
Yeah,
free to add some if you guys. I know Jasmine, you used your book,
Mhm.
vacation book. That would be helpful
Yeah.
if you could add like an in-text citation.
Mhm.
I
Um,
used a few things from the Mayo Clinic, so I'll throw those in. So
yeah.
the professor watching this, just know that we're going to add our citations in at the end. We're going to
Mhm.
make it all perfect. This whole document's going to look great.
Yes. So
Thank you for watching, Professor.
Yeah.
Thank
how
you.
about we
Thank
all
you.
try to just get the citations in by like Sunday, just so we don't have to do them. Yeah,
Okay.
All right.
Sounds
that
good.
works for everybody.
Okay, sounds good.